our fifth point today concerning the failure following the pulp therapy. We already finished the axis, putting selection, the obturating and the medication material. What about the failure? It's very important. What about the failure? We should manage as a dentist or a clinician. You should manage with the failures. We should know from the beginning what about the causes and how the form and the criteria and how to manage. What about the causes we see? I summarize it either pre-operative or operative or post-operative. Pre-operative failures, misdiagnosis, wrong selection of the case. For example, you select an old age tooth near exfoliation to make a pulp therapy, it's failed. Improper case selection, the same. Operative causes, you make a perforation and go proceeding for pulpotomy, make a perforation, make a ledge or longitudinal fracture during manipulation. Post-operative cause, either improper selection of the final restorative materials, leakage and recurrent caries and failure of the extracorneal coverage, improper check of occlusion, high contact leading to failures, trauma of the iatrogen or trauma to your treatment. This either the cause may be the cause of failure, to summarize, either pre-operative, post-operative or operative. What about the criteria? How it be appear to us the failures? How the form it will be get to us at the failure following the pulp therapy, either clinical or radiographic. Clinical, by default, pain on percussion, the patient come to your clinic, doctor, I'm feeling pain on percussion, meaning something pathological, inability to function with the tooth, mobility, as we've seen here, sinus, in the buccally, sinus appearance. Number two, early exfoliation, which is very important due to low-grade chronic, this is a criteria or the critique of the inflammation, low-grade chronic asymptomatic localized infection. It's believed that the pulpal treatment teeth lost or exfoliate earlier due to the irritation of the capping material from the caries before, leading to infection, the infection leading to premature exfoliation. Low-grade, chronic, a long time, asymptomatic without painful to the patient, localized to the tooth infection. So this is the clinical form of the failure following the pulp therapy. What about the clinical or radiographic X-ray? When you make the X-ray, either number one, internal resorption, which is the most frequent after several months, appear after several months after pulpotomy, as we've seen here in the radiograph, internal resorption, due to unexplained osteoclast activity, stimulation of the osteoclast activity, leading to failure of the technique. Treatment in the primary teeth, extraction, internal resorption in the tooth, in the primary teeth, extraction. But in the permanent teeth, we can put intracanal medication to stop the osteoclastic activity, and the osteoclast activity make root canal treatment. This is about the internal resorption. But in the external resorption, whatever primary or permanent should be extracted. But internal resorption, we can put intracanal medication, stop this activity, the clastic activity, osteoclastic activity, and then put the obturation material and then go on for the endodontic treatment. Second point, with the alveolar abscess, may be developed some months after pulp therapy, as we've seen in the X-ray, usually remain asymptomatic because we already make a pulp therapy. The patient is not feeling any source of pain, location around the apex or the furcation area, and the most common in the furcation area. Fistula opening may be present, indicating chronic infection for a long period of time. What about the treatment in the primary teeth, extraction, and then the permanent teeth? Can make full RCT and the treatment upon several session, about several clinical visits with the systematic or systemic medication in between.